you're recording now for some reason.
Oh, I'll tell you why, because this was checked out.
Dr. Greg Martin is a professor of medicine at Emory University in the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine, where he's the executive director, division director. Dr. Martin serves as the director of research for the Emory Critical Care Center and the director of multi-institutional clinical research network within the NIH-funded Georgia Clinical and Translational Science Alliance. He's also the section chief of Pulmonary, Allergy, Critical Care, and Sleep Medicine at Grady Memorial Hospital, where he also serves as the director of the Medical and Coronary Intensive Care Unit. Dr. Martin's research includes clinical and translational research in critically ill patients, with his primary interests being in sepsis, multi-organ failure, and acute respiratory distress syndrome. He's clinically active in both pulmonary and critical care, and is an active teacher in pulmonary and critical care fellowship programs. Dr. Martin is a member of several professional academic societies and various clinical and executive committees at Grady, as well as secretary of the executive committee of the Society of Critical Care Medicine. He's a highly sought out speaker at local, national, and international medical conferences, and has authored hundreds of research articles, editorials, book chapters, abstracts, and web articles. He was the founding editor-in-chief for the Open Access Journal of Clinical Trials, and has served on the editorial board of the medical website WebMed. Of his many awards and honors, Dr. Martin has received the Golden Apple Teaching Award from Emory University and was named one of the best doctors in America. I think that doesn't even do him justice, so let us all please welcome Dr. Greg Martin. We're very excited for this talk.
Thank you. That's
Very
very kind, and it's also obviously overdone. So let's see if we can get the slides.
Correct.
Yeah. So while we're doing this, let me just back up and say one other thing about the Spike Out Sepsis event. So for those of you that are more local, it is really a fun event. I'd encourage everyone to come. And the thing that I would add to that is that we mentioned that even if you can't play, you can log in and donate some money, which is great to contribute. But also recognize that if you want to support one of the teams, you can donate money to the team, and that money actually can go to buying them an advantage over another team. So the way that the tournament works is you actually get things like the other team has to sit down while you serve for 1 point, or other little things. So I would encourage you to do it. It's a lot of fun, but even if you can't be there, it's a great event to support one way or the other. So I don't have any particular conflicts of interest. Rita mentioned that my service for SCCM, I serve as the society secretary right now, and I've been that for the current year. Otherwise, most of my conflicts are about research, as we talked about in sepsis and other things. So what I'm really going to spend time talking about is less is more, and particularly what I mean by that. And the best implementation of that is the Choosing Wisely campaign. So I'll spend a bit of time talking about that, and then particularly talking about evidence of less is more. And then the contrary side of that, what does it mean to be more is more? Are there ways that more can actually be more? And we'll talk a little bit about that. And then finally, we'll wrap up and talk about how you actually might do less is more, meaning how can you implement this in your clinical practice? So let's start off, we'll talk about value in healthcare. So when you think about value, we often define that in healthcare as being quality over cost. And that's really true of any industry in the world. You can define value as quality over cost. In healthcare, we probably would include other things like access to care, or the services provided, the resources and things that are provided to patients. But we can simplify that. Really, all that falls into quality, right? So when I think about it and the way I define value in healthcare, it's quality over cost. All those things go into quality, and then there's the cost of care. So why is this relevant? It's relevant because when you're thinking about less is more, this equation can actually help you think about it, right? If you provide higher quality care, that's better, but you may be able to do it at a lower cost. So one basic tenet of less is more is you may be able to do a higher quality of care at a lower cost. That clearly is beneficial to the patient. It's also beneficial to the rest of society. But there's other aspects of it too. It's not just the financial cost, but there's other things, and I'll show you a little bit of the reasons why we think about it that way. So one basic tenet of less is more is just because we can doesn't mean we should. And this is not only certainly true everything in healthcare, but it's really true in the intensive care area. So in critical care, we have a lot of things we can do. and it doesn't mean that we should. There's certain things that we should do, and we should do them well, and we should do them in the right time. But there's other things that we have the ability to offer. We can dialyze everyone. We can offer a variety of therapies to people, like chronic persistent mechanically ventilated patients. That doesn't mean it's the right thing to do. And we have to then think about how do we really optimize each individual patient's care, and thinking about the equation that I showed you, how do you provide high value care, meaning high quality and a low cost. Okay, so that last part, sort of thinking about just because we can do something doesn't mean we should. One way to think about that too is the medical principles, the principles of medical ethics. So one of them is beneficence. So clearly we shouldn't be doing things for patients if it doesn't benefit. That's a very basic principle. I think we would all agree with that. But another one that we don't think about as often is justice. So when you think about, I could offer dialysis or mechanical ventilation or stroke therapy or anti-epileptic therapy for status epilepticus or chemotherapy for patients, all those things require resources. And we often think at the individual level, this is my patient and I want to do all the right things for them. But you also have to realize that every choice we make has implications for society and the healthcare system. So we don't often think about it that way, but think about it in terms of the flu epidemic, which we saw in the last year, and we've seen over time with the H1N1 epidemics, for instance. And when those happen, we may have shortages of things. So if you may remember a few years ago, we had shortages of mechanical ventilators. So we actually went through a process of trying to decide, how do we decide who gets a mechanical ventilator? The next person that comes in, what if that person is more than likely to survive? What do we do with someone who's very likely to survive, but there may actually be someone upstairs already on a ventilator that's unlikely to, right? So then it becomes a scarce resource, and that's where justice comes in, because you do have to start thinking about how to provide the best level of care, net benefit for everyone, but thinking about it on a distributed basis. How does this apply to society? And that's another important principle when we're thinking about less is more, because less is more is both on the individual basis, providing the best care for that patient, but also to make sure that we think about how we use our resources for everybody together. Okay, so with that in mind, then, thinking about less is more, a key concept there is overuse. And there is actually good literature on overuse. And I'll show you actually a lot of the data we have now for the principles of less is more and overuse and other things really comes out in the last few years. So this one really came out in the last decade or so, thinking about overuse. And what the point is that overuse isn't simply overuse. It also is a patient safety issue. So if you think about 1/3 of all care delivered in the US may actually be overuse or unnecessary care, it's important to realize that when we think about that or when we do that, there are implications of that. There's potential physical harm because we may be doing something that has maybe not as much benefit, or maybe the risk-benefit ratio isn't where we'd like it to be, meaning there may be some risk and maybe more risk than we'd like for the benefit that that patient may accrue. But there's also the emotional harm and even the financial harm. The financial harm is pretty obvious, right? You may be doing procedures and things on people that don't have as much benefit and obviously are going to incur cost. But there's also the emotional harm of offering therapies to people that they expect to be beneficial and or expect to improve their quality of life, and then when they don't, they end up with a different expectation and or sort of a loss of sort of reliance and comfort with the healthcare system. So one way to think about this too is this quote. So as evidence increases about the harms from healthcare overuse, physicians, and I would say it's not just physicians, it's clearly the entire healthcare team, and the fact that we're a multi-professional critical care system tells us that. But we all have a professional obligation to reduce these events on both an individual patient level and across healthcare systems. And this last sentence is important. Overuse may need to be considered equal to adverse events and reviewed in the same context. So think about that for a second. We review adverse events all the time, right? If you're a pharmacist, you probably review adverse drug events, right? We have morbidity and mortality conferences where we discuss things that didn't go well, clinical outcomes that were not as good as we'd like, patients didn't transfer to or from the unit in a timely manner, the therapy wasn't administered in exactly the way we wanted. And if that had an adverse outcome on the patient, that's clearly evident. But then there's other things like sentinel events that we often review, even though it didn't cause a harm, but it could have caused a harm, and we still want to learn from it. We don't think about that for overuse. We often don't pay attention to overuse in it all the same way because it's not clear to us that it's an adverse event. But if you think about the principles of medical ethics and the way we should be delivering care and the fact that there is a value equation that goes into that, thinking about overuse the same way we think about adverse events actually is a relevant way to think about it, right? And so one example of overuse may be thinking about the finances of what we do. So those of you that are maybe a little bit older, which aren't very many of you here, but if you may go back and think about when have you seen reviews of drug prescription or other activities? And often that comes up because the finances that go along with it. So an example would be using colloids in the 1970s and 80s when pharmacy budgets exploded because people were using colloids frequently, and they realized that, gosh, these are relatively new and are sort of being used more frequently, and they're consuming a huge amount of our hospital budget. Why don't we review and see if their use is appropriate, right? But that wasn't because there was just a simple concern of overuse, and it wasn't necessarily because there was a concern of adverse events. It was a concern because people were looking at their budgets. And that's where we're failing to really detect overuse and think about its implications both individually for the patient, but also for our healthcare systems and our society. Okay, so I wanted to introduce this concept of a learning healthcare system. The idea here is to marry or join our clinical care and our clinical research. And so when you think about that, clinical research informs clinical care, right? If we do a research study and we find a better way to take care of a patient or new evidence that helps provide clinical care, we try and apply that at the bedside. But almost all, essentially all, clinical research comes from clinical care. There's the clinical question that comes up. How do we take care of that patient? What's the best therapy for that? And that then drives a clinical research question. Putting those things together creates a learning healthcare environment, meaning you have a health system that actually works in a continuous circle where you're thinking about what's the research question, what's the clinical care, and let's move back and forth between those continuously. And when you do that, you end up with a much higher quality healthcare system. So this is a sort of a system that was thought about and or proposed 10 or 15 or 20 years ago now within the Institute of Medicine. And it's really hard to accomplish, right? So the idea of having all these things married and running together sort of continuously is a real challenge. But we see good examples of that when we think about sort of quality programs that are run in this continuous cycle of quality improvement. But the same thing is true when you think about clinical care and clinical research. Okay, so let's shift gears a little bit. How many people are familiar with the idea of therapeutic illusion? Anyone ever heard about it? Ideas of what it means? So you could think about it in terms of, get it to load. There we go. This cartoon, but it's not exactly what I mean, right? The idea that, okay, well, you're over-medicated, there's a medication for that, is clearly a therapeutic illusion of some sort. But the real concept of therapeutic illusion is that we, as humans, and certainly as providers of any sort, want to provide the best care. And that means that we often think about and or try and deliver things because we're trying to provide something to the patient. Even if it's a patient who's critically ill, moribund, has sort of the worst case of pneumonia you've ever seen, you want to provide something that's going to try and make that patient better, right? And so in that example, you may say, well, we need antibiotics, we need all the treatments for sepsis, we need a good mechanical ventilation support, we may need dialysis. But you may also be thinking in the back of your mind, we also need palliative care, or we need to have some other family discussions, right? Because it's unlikely this is going to end well for an elderly, sort of chronically ill patient with severe pneumonia. So when you think about it, patients and providers are always looking for the next best therapy. We're also thinking that when people are referred, and this is true for patients who are referred into our ICUs or people who are sent from someplace into the ED and then being transferred to the ICU, that we want to offer something, right? It's awkward to have a patient referred to us either in clinic or in the ICU, and we take care of them, we send them back, and it's evident to the person that sent them to us that we didn't do anything that they couldn't have done, right? So that is a therapeutic illusion too, because we're looking at it and saying, gosh, I really feel like I should do more. And in fact, we then begin to think about all the multiple tests and therapies that we can do because it makes us feel like we're doing something. That's clearly not necessarily healthy, but it does help address this question, or maybe the concern that we perceive that patients often feel that being told that watchful waiting is okay, or, oh, you're getting all the right therapies, it just takes time. They don't always feel comfortable with that. And in fact, it's one of the reasons why doctor shopping and other things occur. But the other component of this is in the ICU, we have a variety of new therapies, right, that come out all the time, whether it's a simple new antibiotic or it's a new machine that we can use for managing or monitoring patients. All these things exist for us in critical care. And so the therapeutic illusion is very real in our ICUs. There's also defensive medicine. We recognize that that's an important component, particularly in the United States. There's also a bit of an incentive problem, right? There's third-party payers that actually incentivize, particularly in the fee-for-service system, incentivize people to do more. If you do more procedures, you're paid for those things. And that may be less common now than it was 10 or 15 or 20 years ago, but it does still exist. And so trying to align the incentives between the healthcare systems and the patients and the providers is really important. And this last point is simply to say, and this is also true in the ICU, that lack of continuity is a challenge. We recognize that from our electronic health records, that if you don't have the records for a patient, you're more likely to repeat tests and or try and do things to try and make sure you're not missing something. But even on the basis of a patient coming from EMS to the ED to the ICU to the floor, all those transitions of care run the risk of a handoff and or a lack of information. So even when we send someone from the ICU to the floor, we may have been thinking and or in the background doing tests for things. And if that's not known and or communicated to the team that's going to care for the patient and plan their homegoing and their discharge, that may not be evident. So all those pieces have to come together to try and make care as efficient as possible. So a lot of that, what I've just laid for you, is the foundation for the Choosing Wisely campaign. How many people have heard of this? Good. So this is a few people. So particularly those of you in medicine probably are more likely to. It actually grew out of the American Board of Internal Medicine, and it got quite a bit of press probably 5 to 8 years ago when it was launched. And basically the concept was to start a dialogue, a national dialogue between patients and providers, and to some extent sort of health systems and third-party payers, of what is the right level of care for each individual patient. So on a very simple basis, if you go to your doctor and they say, I think you have bronchitis, an upper respiratory infection, and I'm going to give you antibiotics. One of the things that they advocate, and you can see some of this in recommendations from the Infectious Disease Society of America, is you should talk to your physician about the benefits of antibiotics for those things, particularly the upper respiratory infections. Is that necessary or is that beneficial to be? So essentially the way Choosing Wisely worked is it advocated or created a platform and a foundation for groups, including essentially any any professional society or other groups who wanted to put a platform or a statement together and make recommendations. So you see up here at the top, the American College of Chest Physicians and the American Thoracic Society made recommendations of the use of chest CT in things like lung nodule or lung cancer screening or working up patients for pulmonary embolism. But all those societies came together and produced 58 pages worth of recommendations. So the Critical Care Societies Collaborative was one of the groups that did that. How many people are familiar with the CCSC? Good. They're a very complex society, not at all what you think. Well, actually they are. They're a collaborative of critical care societies. So you can find them at ccsconline.org, and their recommendations are there. And I'll come back to those, but suffice it to say for now that the CCSC is the major critical care societies in the US, working together, 150,000 members represented, and trying to sort of have patients and or stakeholder interests at heart to provide the best level of care. So Choosing Wisely in the ICU really transitioned from the evidence that we have. So what's the evidence we have for less is more? And I'll start off with sort of a conceptual thing. So start back really 20, 30, probably 40 years ago, when our traditional approach for managing patients with ARDS. So if you have patients with ARDS on a mechanical ventilator in an ICU, if that was 30 years ago, your approach was to normalize blood gases. You wanted patients to seem, or at least measurably be, as normal as possible. Normal pH, normal PCO2, normal PO2. That was the goal. We thought that that physiologically was the right thing, that a patient would do better if their acid-base status and their gas exchange was as normal as possible. But over time, we realized that ARDS was an injury to the lung, and that doing those things required quite a bit of respiratory support, and some of that respiratory support might actually be injurious. So we transitioned to saying, well, maybe we should think more about the lung and less about normalization. And so the first sort of thinking of this was a guy named Keith Hickling in Australia, who as early as the 1980s said, I think we're injuring the lung. Why don't we try doing something less? If that's part of the problem, let's use sort of smaller tidal volumes on the ventilator and see if maybe that would be beneficial. And what he showed is that when you do that, you raise PCO2. So he called that permissive hypercapnia, meaning that your CO2 rises, but you're allowing that to happen and it's okay. pHs would go down even to the 7.0 or 7.1 range. And that was okay. And remarkably, mortality went down quite a bit. Mortality went from what you see is about 40% down to 16%, even adjusting for severity of illness and other things. So that was really the foundation for the ARDS network many years later to do their tidal volume trial and say, why don't we compare low tidal volumes to regular tidal volumes in patients with ARDS? And yes, in fact, it reduced mortality by 25% and got people off the ventilator faster. So I like this biologically because less is more, meaning it's like less tidal volume. That's easy, right? I mean, it's less actually in numbers, but it's also less, meaning we're not trying to normalize people, right? One of the things that we've learned over time in critical care is that trying to make someone appear as if they were walking around the street is not the right thing. So a normal acid-base status, a normal PO2 is not really the goal in a critically ill patient, right? A lot of the things that we're still trying to understand is the body responds to injury or illness in a certain way, and we need to understand when those things are biologically protected. We shouldn't, in other words, be trying to fix those things or normalize them. So there's a lot of other things. So how many people prescribe fluids or are familiar with giving fluids, right? So fluids are a drug. We don't often think about that, but more and more, and this is just one example, of the more fluid you give is almost always associated with a worse outcome. So years ago, we used to say, well, that's because sicker patients require more fluids and sicker patients are also more likely to die. So it's not the fluids, it's just the patient that's sick. That's not necessarily true anymore. And in fact, we're now getting randomized trials looking at more and less fluid, and we see that less fluid actually is beneficial in all the cases. I can't tell you that we're there in terms of knowing exactly how much fluid to give every patient, but as we move towards more personalized critical care, that's one of the things we're going to have to do, is how does each individual patient respond to fluid and how do we decide how much to give? Now, here's an interesting perspective too, and this one really just came out this year, but this is absolutely proposing less is more. So you can read the title here, Unproven and Expensive Before Proven and Cheap. And the example here is prone positioning in an ARDS. So if you recall, the PROCEVA study demonstrated that prone positioning in patients with severe ARDS was better. It saved lives, it reduced mortality. And that was published in 2013. So earlier this year, they published this commentary, and what they did is they analyzed studies of ECMO, extracorporeal membrane oxygenation, another form of support for severe ARDS, and they analyzed it and said, tell me what happened before 2013 and tell me what happened after 2013 when prone positioning was sort of demonstrated in the literature. And what they showed is that prone positioning was used relatively commonly before 2013, but in the studies published after that, they didn't really talk about prone positioning. So that raises two real issues, right? One is that if prone positioning was demonstrated in 2013, why are we potentially using it less, right? And that's their point, that it's proven and it's cheap and we should be using it, and it may in fact prevent people from needing ECMO. But the other issue is, are we actually reporting it accurately? So if we're doing ECMO trials and we're not reporting the use of prone positioning, like maybe it is being done or it's being tried in some patients but not all, then it's confounding our ability to interpret ECMO trials too. And that was their other concern, is that inferences about the efficacy of ECMO may really be a very limited use. So this is sort of a direct sort of example of thinking about how less may be more, and in this case, less being proven and cheap. I'll give you a couple other quick examples. So early renal replacement therapy, with no disrespect to my friends and colleagues who do early and or CRT in our ICU patients. But there's been some nice studies trying to demonstrate the efficacy of early renal replacement therapy, and it's been really difficult. And this is one of the more recent studies where they compared early versus delayed renal replacement therapy. And the important thing here is that those patients who got later therapy, meaning they weren't initiated early upon ICU arrival, that only about half of them needed renal replacement therapy. Well, that would imply that about half the patients who got RRT didn't really need it, but we were doing it early, even though ultimately had you not done it, they wouldn't have needed it. And there are complications of that, right? So about twice as many patients got central line associated infections related to that. So they had their lines in for longer because they were getting dialysis. So you have to think about, when less is more, in this case, maybe watchful waiting and or sort of more supportive care would be appropriate in order to avoid the complications of early renal replacement. We often think about early parenteral nutrition. So PPN is another one that's been studied a lot over the years, and there's certainly appropriate use of parenteral nutrition and enteral nutrition, but in this case, it's been very hard to demonstrate early use of TPN. So if you look in the adult literature, large studies have demonstrated that mortality is higher if you get early TPN, or mortality is lower in this case, as it says here. Mortality is lower if you get late initiation of TPN. You also have fewer infections. The same thing's true in critically ill children, fewer infections with late implementation or delayed implementation of TPN, and a higher likelihood of being discharged alive from the ICU. This is even true in general nutrition. So there's sort of two other strategies that we thought about for enteral nutrition. One is early versus late, and on the right side here you see the Eden study, which was done in ARDS patients, and it showed that early nutrition, Eden was early versus delayed enteral nutrition, that early nutrition didn't have any benefits, and the only thing it really resulted in was more feeding intolerance. As you might guess, people that are coming into the ICU and are trying to feed them early, they're less stable, they're more hemodynamically unstable, there's more complications trying to feed those patients. But if you look at the Omega study, which was the other approach we've tried to use in the ICU, is understanding sort of the antioxidant and or supplemental formulas that we can use to affect the immune function and or the inflammatory status of patients. The Omega study used all those antioxidant formulas and showed that, in fact, you had more diarrhea, you had more organ dysfunction, you had more time on the ventilator, you had less time in the ICU, less time out of the ICU, more time in the ICU, and you had a higher mortality. Not quite statistic, like 0.052 or 0.054, but still clearly no benefit. If anything, there's only harm with those antioxidant formulas for ARDS. So again, simpler when we think about what we do traditionally and what recommendations exist now, is to provide enteral nutrition was possible. You don't necessarily have to do it immediately, and you use sort of a standard isocaloric formula. Now, another part that we think about, I guess maybe the other major part we think about in the ICU is antimicrobial stewardship. And antimicrobial stewardship can be really important both on a hospital or institutional basis, but also on an individual patient basis because of the resistance patterns that we see in a lot of hospitals. So when we think about antimicrobial stewardship, one of the questions that comes up to us in the ICU is, how do you decide what antibiotics to give and when you give them, and particularly when you stop them? And there's growing evidence for things like procalcitonin that might actually help guide some. So the best evidence for procalcitonin in the last few years has been to suggest that we can use it to help decide when to stop antibiotics. So if you look at this is a systematic review, and it suggests that you can get about 3 fewer days free of antibiotics. Sorry, 3 fewer days of antibiotics, 3 more days free of antibiotics. If you look at it in sepsis, the data in sepsis again suggests that you're about 1.5 days less of antibiotics. If you look at it in just more general critically ill patients, you find that procalcitonin potentially helps you stop antibiotics about a day to a day and a half earlier. Now, is it definitive? Can you use it to decide when to give or stop antibiotics? No, it's an adjunctive piece. You use it along with your microbiological results and your clinical intuition and what else is going on with the patient, but it often can help us shorten antibiotic courses. And then the final thing, and sort of the less is more component, is oxygen therapy, right? So we've always sort of slapped oxygen on almost everyone that walks into the ED and certainly anyone in the ICU. But increasingly, we've begun to question that. And there's been data in cardiac patients. Do we need oxygen support in those patients? And there's data that suggests that probably we don't. But more in the ICU, now there's randomized trials. So you see this very recently in the last couple of years, a randomized trial comparing higher and lower oxygen saturation. So the low sort of conservative oxygen therapy meant an SpO2 target of 94 to 96, sort of right in the middle where you might think is okay. And the high target was 97 to 100. So, sorry, 94 to 98 versus 97 to 100. So you're basically saying, do you want someone at the high end, thinking that you want them to be fully saturated all the time, or is the middle range okay? And it's clear from this that in a patient study of about 450 patients, that conservative therapy is actually better. And it's not only better, it saves lives. There's fewer patients dying. And so if you then look at the most recent data, this really just came out in the last few weeks, is from Lancet, a systematic review of 25 studies looking at oxygen therapy, sort of more conservative or more liberal oxygen therapy in a variety of patients. It's very clear that high sort of liberal oxygen therapy is not beneficial, that more conservative therapy works just as well. And in fact, absolutely less is more, right? A lower oxygen titration, lower oxygen target, and giving less oxygen actually results in better survival, whether it's in the hospital, out of the hospital, or in long-term follow-up. Okay, so one last thing. So how many people do routine or see routine daily chest x-rays done in the ICU? It's not uncommon, right? Yeah, so even though this is one of those great examples, I think, where you ask people what their protocols say they do, and then you look and see what actually happens. And it's much more often that we order daily x-rays than we think we do, right? But there's good evidence, and this is not new evidence. This is evidence that's been around for a while, that daily chest x-rays are not really helpful. So this is another great example where absolutely less is more. And this is just one of many studies showing that you can safely eliminate daily x-rays. It doesn't mean you don't ever get x-rays. it means that you now get x-rays for clinical reasons. If the patient desaturates, if you think the tube is migrated, if the patient's had a procedure, there are reasons to get chest x-rays. And then on average, at least in our hands, you'll probably get x-rays every second or third day because something happens. But you don't order them routinely. You don't order them just on a daily basis. Okay. So the flip side of less is more is sort of the fun side. What is more is more? And what does that mean? So in what cases could more be more? Well, I think in some cases, very simply, we'd say, well, there's certain conditions where more absolutely is more. And it may be on a timely basis, right? So early stroke therapy, STEMI therapy, trauma therapy, sepsis therapy, cardiac arrest therapy. There are reasons and conditions where we would absolutely believe that more, meaning sort of early and aggressive therapy, is appropriate. There's probably also more is more, meaning on the other end of that, if we did more palliative and or end-of-life planning, that would probably be more too, right? There's less evidence for that, although there are data and evidence that say that does work. So you have to think about that as it applies to your patient. And so how is it that it works? And really, I think the key here is that timely and evidence-based care can have impact downstream, right? And I'll show you some examples of that. So if you do something up front in the ED or early in the course of the hospitalization, that may result in less need for invasive procedures later, less resources, a better hospital disposition. The patient may go home instead of to rehab. They may be more functionally independent. There are a lot of reasons why sort of early aggressive therapy, in case more is more, actually does work. So one example of that would be revascularization for patients with cardiogenic shock and acute MI. So this is not the only data for this, but this is one good example where if you take patients to the cath lab and do PCI and open up the artery, that's the infarct-related artery for patients with cardiogenic shock from an acute MI, you can actually save their life. Their shock's going to resolve more quickly, and they're going to have a much better chance of survival. So this is good data that says, yes, actually mortality is better, both in the short term and in the long term. But I would still say, and this is just sort of a point, is that even when more is more, less is actually still more as well. And so this is actually more recent data looking at in those patients who have acute MI and cardiogenic shock, and you take them to the cath lab, do you open up just the infarct-related artery and ignore the other stenoses that you're seeing because a lot of patients have multi-vessel disease? And what happens to those patients? And the example here is that actually, if you do more PCI, if you open up those other arteries as well, that's not a good thing, right? The key here is timely and effective therapy. And opening up the infarct artery, which is going to restore blood flow to the left ventricle and probably resolve cardiogenic shock more quickly, is also going to help perfusion to the other coronaries, and you don't need to intervene on those other coronaries. In fact, there are complications to doing that, and as you see here, mortality is higher if you do multi-vessel PCI, as opposed to only doing the single vessel, the culprit vessel PCI. Okay, what about in stroke therapy? So when we think about stroke, one of the major evolutions or revolutions in the last decade or so has been the use of TPA. I will point out that a lot of that data, or a lot of that research was done here at Grady. The window for giving TPA has evolved a little bit. It's about 4.5 hours. But this is a good example of more is more on a timely basis. So this is a very recent study that shows of 65,000 people, if you get TPA in the first 60 minutes compared to the first 270, right? So you've got 270 minutes, 4.5 hours to give TPA. If you do it in the first 60 minutes, your outcome is better. So even within that window, the 4.5 hour window, earlier is better. And that's where I think I would look at that and say, okay, if I can give it earlier and those patients in the first 60 minutes are more likely to be discharged to home, have better functional capacity, more functional independence, then that's a time-dependent more is more example. And we need to be cognizant of that. Now the other part, and I do this partially because it's important for us to realize all the things we do at Grady, is that there are a lot of patients who present with stroke after that first 4.5 hours. So one of the examples, and this was just published earlier this year, is Raul Nagara, who's one of our neurointensivists here, did a nice study where he took patients who were out of that window in the 6 to 24 hour period who had substantial stroke symptoms. And what he did is he randomized them to thrombectomy versus usual care. And what he found is that if you do thrombectomy in those patients, even in the window where you would think the brain has already been lost or beyond the window that's been demonstrated for TPA, for instance, you can still improve functional independence. You can improve their modified Rankin score in terms of their functional capacity, and you can improve their functional independence at 90 days substantially, a 13% level in one group and a 50% in the other group. So this is a good example where even if you miss the window, timely care still may be important, right? So it's thinking about the patient who presents at the 7th hour or the 10th hour. There's still things you can do for them, and time still matters in those patients. Okay. And then the last example I'll give you is, what about in sepsis and ARDS? And so this is one of the areas that I've been particularly interested in over years, is what about fluid therapy in those conditions? And if you look at sort of the combined, you think about sepsis and then sepsis causing ARDS, there's fluid components to both, right? So in sepsis, we think about early fluid resuscitation being important for improving organ perfusion, preventing organ dysfunction, and saving lives. But in ARDS, we say, well, but too much fluid is bad. We need to be more fluid conservative. So if you think about that, what you would expect to see is that there's two components to fluid therapy. And what you see is exactly that. So this is data out of St. Louis. And what you see is on the far right side, people that got inadequate early fluids as part of their septic shock resuscitation, but then they got more liberal fluids later as part of their ARDS. Those people had the worst outcome, which is exactly what you'd expect. In fact, the outcome, they had a mortality of 80%, which is really high for patients with septic shock and ARDS. But if you look at the other end, on the left side of that graph, the patients who got good sort of early fluid resuscitation with sepsis, but then converted to more conservative after that, they had a mortality under 20%. So that tells you sort of what you potentially can accomplish if you do everything right in a patient with septic shock and ARDS. And as you can see in the middle, then you've got the other groups, right? Just as you would expect, the patients who were good on one side but bad on the other, they end up right in the middle. Mortalities are sort of 40 to 60%. So more is better in this case, but timing matters, and you have to be very specific about that for each patient. And finally, we realize that mobilization is the other. So I don't know if this is less is more because you want less immobility, or more is more because you want more mobility, but mobility is important. And it's one of the things we're barely scratching the surface of trying to understand this, but it's very clear that mobility is an important component of the way we manage patients in the ICU. Okay, so the biggest waste in medicine is waiting. So if you think about all the things I just told you about timely care and the way we implement things on a sort of timely basis for sort of those conditions where it's a time-sensitive disease, the same thing is also true for the daily patient in the ICU. So waiting for, as an example, liberating someone from the mechanical ventilator is not a very effective strategy. The more effective strategy is to be proactive. Wean sedation, wean mechanical ventilation, minimizing immobilization, and that is actually going to increase value, right? Because you're going to reduce the cost of care, you're going to provide higher quality care to that patient, and that's the ABCDEF bundle. So I hope you're familiar with the ICU liberation campaign and the ABCDEF bundle. That A is prioritizing treatment of pain, B is undertaking the daily spontaneous breathing trials and spontaneous awakening trials, C is being cognizant of the choice of drugs that you use for sedation, D is monitoring and minimizing delirium, E is facilitating early mobilization, and F is empowering and engaging families in the care plan. And if you put all those things together, the collaboratives that have been done by the Society of Critical Care Medicine and other groups really demonstrates a high level of efficacy and also a high level of teamwork to make this happen, a very high functioning unit. So less is more. Well, you could say, well, less, more was shot, and there's no less and no more. It's on the humorous side, but I'd rather leave you with the emoji for less is more. So less is more, right? Think about that. That's exactly what we're talking about. So how do you do this? So let's go back to the Choosing Wisely campaign. So again, 150,000 member stakeholders in critical care, and they put together a list of 5 things based on their sort of work and their review of the literature. So number 1, don't order diagnostic tests at regular intervals. I showed you the data for that on chest x-rays. There's even data that we've generated from people at Emory looking at routine blood gases, routine transfusion thresholds, routine laboratory work. If you avoid those things and only order things as needed, right? Don't order a chemistry panel on a CBC and whatever every day. We don't need that. And I think you can extrapolate the same thing from the experts. Number 2, don't transfuse red blood cells in hemodynamically stable, non-bleeding patients with a reasonable hematocrit. There's a few caveats in there, right? Reasonable hematocrit and all that. But it's clearly true. We've changed our transfusion thresholds over the years, and we clearly don't need to be transfusing patients who are hemodynamically stable and not bleeding. Don't prescribe TPN in adequately nourished patients during the first week. There's evidence that actually can be harmful, so there's no reason to be doing that in most patients. Don't deeply sedate, mechanically ventilate patients without a specific indication and without attempt to liberate or lighten the sedation of the day. And number 5, don't continue life support for patients at high risk of death or severely impaired functional recovery without also offering comfort care. Sort of the other strategy, thinking about how well that might fit into both patient-centered care and the high quality care that we're trying to deliver. So all those things together, if I was to say, how would you deliver this? I would say, number 1, pick one of the elements of the Choosing Wisely campaign. You're probably doing some of them. Maybe you're already doing non-daily x-rays or non-daily labs. Maybe you're already doing the ABCDEF bundle. You're doing some of these things already, but maybe you're not doing all. So pick one of those and do it. Number 2 is absolutely start working on the ICU Liberation Bundle, all 6 of those components, and put those together and start working with your team to make that happen every day. And number 3 is go back to that healthcare learning environment. Think about the resources you have in your environment and how you can do this. And that doesn't mean you have to go create a clinical research infrastructure. It may mean that you work within your QI and other sort of structure to think about the questions that arise in your patients, study them, and feed that information back to deliver better patient care. If you do those 3 things together, not only will you figure out that less is more, but the quality and value of your care will go up. So here's a nice quote that I'll finish with. Sometimes more is not necessarily better, and a barrage of tests and therapy should not automatically imply thoroughness in care. That's the other sort of tenet of less is more. We often feel like if I do something, that's better than doing nothing, but that's really not true. And so the other thing that I'll leave you with is don't just do something, stand there, right? So this is one of the things that was written by someone that I know as a mentor many years ago, but the idea here is exactly the same. You don't necessarily need to do something immediately. You need to think about your patient and what's the best approach to that patient, what's the evidence for that, and make sure that you're delivering the high value care that they deserve. All right, so I now have 5 questions for you, okay? Everyone ready? Number 1, as per the Choosing Wisely recommendations, which practice should be avoided in the ICU? Number 1, or A, deep sedation without a specific indication. B, prescribing TPN in adequately nourished patients during the first week in the ICU. C, transfusing blood in the hemodynamically stable, non-bleeding, reasonable, adequate patient. D, continuation of life-supported patients at high risk of death, but I'll offer for comfort care. And E, all of the above practices should be avoided. Thank you. Good for you. All right. We just saw it. You're doing well. So, true or false? Usual care for every patient in the ICU should include the ICU Liberation A, B, C, D, E, F bundle. True. Very good. All right. So these are not hard, but they're good reminders. A little bit harder now. What is a component of the ABCDEF bundle? See if you were paying attention. A, schedule daily spontaneous breathing trials. B, family engagement. C, minimize delirium. D, promote early mobilization. Or E, all of the above. All of the above. That's right. It is all of the above. All right. So getting a little harder. What rationale best supports the more is more approach? More early aggressive therapy decreases the need to identify evidence-based care later. B, more timely early therapy decreases the need to consider the ABCDEF bundle for each patient later. C, more timely aggressive therapy is appropriate when it leads to less care needed later. And D, more timely aggressive therapy leads to the need to consider the Choosing Wisely principles in the ICU. Shout it out. Say it again. C, right? So the idea here is that the more timely aggressive therapy is particularly appropriate when it leads to less care later, right? It shouldn't change your need to consider the ABCDEF bundle. It shouldn't make you decrease your need to identify evidence-based care. It certainly shouldn't make you go back and rethink the Choosing Wisely principles. All right, the last question. All of the following factors are examples of value in everyday ICU practice, except A, focus on the computer work with laboratory results. B, implement watchful waiting to evaluate patient status. C, build consensus in clinical practice in areas with inconclusive evidence. And D, spend more time at the bedside to treat patients. Which one of those is an exception? A, right? So A is clear, and it's probably something that we all do too much. I would argue that our EHRs don't really help us with that. But we need to think about that every day, right? Because as practitioners, we need to be making sure that we're actually devoting our attention to the patient. And sometimes that's that is actually looking at data. We might be wanting to try and determine the best therapeutic approach to that patient. But it's not just sitting there looking at lab results and spending time writing our notes. That's not nearly as effective, and it's not very engaging for the patient. So that's all I have for you. I would say if anyone has questions or anything, you're welcome to email me, contact me. For those of you that don't know about our Critical Care Summit, we have a Southeastern Critical Care Summit, which ran in May, will occur again next year in 2019. You can find that online. And if you're really interested in all the things that I do, you're welcome to follow me on Twitter as well. All right. Thank you, everyone. Questions? And while she's doing that, let me say one other thing. So SCCM, you probably saw there's less is more, right? So the less is more pin, which was Jerry Zimmerman, the SCCM president's talk at Congress this year. They have these little boxes which have a pad of paper for the ICU Liberation Bundle. You can use it. It's also got less is more pens. And if you want these, I'll leave this with you guys for the Southeast chapter.
Thank you.
But you can also buy them from SCCM, where if you're at one of their meetings, they'll have them to pick them up.
Sounds great. Thank you so much.
Yeah.
And at this time, we're also happy to take questions from all the remote sites. I'm going to open.
Find them. Yeah.
Yes. And you guys feel free to either type them into GoToWebinar, or you can text them to us and we'll read them out loud.
You want to hear? Michael?
Why does the ABCDEF bundle not include a statement about volume status?
So the question is, why does the ICU Liberation Bundle, the ABCDEF bundle, not include a statement about volume status and our use of fluids? And so while I agree that there is good reason to do that, and I do think it has an impact on liberation, both from the mechanical ventilator and from the ICU, I think we don't yet know how to implement that as well as possible, right? So I showed you the data on early resuscitation and sepsis and later fluid conservative for ARDS, but the problem is our ICUs, whether it's a MICU or a SICU or other ICUs, are fairly heterogeneous. And to say that we champion a single fluid strategy for all types of patients, I think is hard. And particularly because it ebbs and it flows and it changes from day to day. So I think conceptually, the way I think about that clinically is I say you need to think about fluids as a drug, and you need to decide every day how you're using that drug. So if you're giving normal saline to a patient, which I would argue is not normal, you need to decide what's the goals that I'm trying to use. What's my goal with that fluid? Am I trying to raise CVP? Am I trying to raise urine output? Am I trying to raise mean arterial pressure? Am I trying to sodium overload the patient? Like, what am I trying to accomplish? And any of those may or may not be appropriate. But if you're just giving fluids because you think it's appropriate to give fluids, then you do need to step back and say, well, but it is actually a drug, and there are a variety of different crystalloids, each of which have different components and different effects, and be much more intentional about your prescription. Yeah.
What are your thoughts on blood draws and going to minimal volume PD tubes versus regular to cut down on transfusion?
Yeah, so the questions about using essentially low volume blood draws and pediatric tubes to try and do that. So there's a variety of hospitals that do that. And so this was about almost 20 years ago now. There were a variety of studies about the effects of anemia in the ICU and how often transfusion occurred. And it showed that basically if you stay in the ICU more than 3 days, you're very likely to get transfused, at least in most sort of medical surgical units. The hard part at the time was that they were studying things like EPO. Could you give EPO to try and minimize the amount of transfusion? And it actually probably has some effect on raising hemoglobin, but not enough to have a real clinical impact. So because of that, then people started to think about, well, could we use low volume tubes? Could we do pediatric tubes? And there's a variety of challenges with that. Some hospitals particularly did it back then, and some still do. It has some implications in terms of equipment. It means sometimes you have to have more and different equipment to do that. It also means, as you know, sometimes we'll send blood to the lab for a chemistry panel, and if we then say, I want to add on to something else, they can do that, but in a pediatric tube, they may not, because they simply have the blood that they ran through the machine and it's now gone. So there are implications for that. I don't think it's a bad idea. It's really a matter of implementing it and showing that it can reduce resource consumption and or minimize sort of hemoglobin and transfusion patients. Other questions? I don't see anything on the webinar. Okay, you want texting you?
Nope. Oh, thank you so much. This was a great talk. I think it's definitely very timely with all of us working very, very busy ICUs. I'd like to remind everyone in the audience that you have 2 weeks to submit for CE. So you all have received the link, and please make sure you do that. Again, thank you so much, Dr. Moran. It was a pleasure having you. Thank you so much.
Thanks, everyone.
All right. Our next meeting is going to be on November 13th, so make sure to save the date. More information to come in your email. Thank you.
Thanks, everyone. Have fun.